Good evening and welcome to our live Q&A for July. My name's Valerie Toswell and I'm a senior orthoptist and patient educator here at Glaucoma Australia. Before we begin, I'd like to acknowledge the traditional custodians of the land we're all joining from tonight. For me, this is Wallumedegal land, and I'd like to pay my respects to their elders, past and present, as well as their emerging leaders. We have a very special presentation lined up for you tonight in honour of National Diabetes Week, featuring a wonderful speaker, Natasha. She brings a wealth of knowledge and a passion of supporting individuals affected by eye disease, low vision and permanent disability. Natasha Sikman is a fellow senior orthoptist and patient educator at Glaucoma Australia, and I'm absolutely thrilled to be working alongside her and delighted to introduce her to you. Her background includes roles at the Royal Victorian Eye and Ear Hospital, Vision Eye Institute, and Guide Dogs Victoria, where she developed her expertise in patient care. Additionally, her academic involvement at La Trobe University as a casual lecturer has allowed her to mentor the next generation of orthoptists, further showcasing her dedication to the field. Tonight, Tash will be presenting the relationship between diabetes and glaucoma, delving into the connections between these two prevalent conditions, discussing risk factors, preventative measures, and the latest research. So without further ado, I'll hand you over to Tash. Thanks, Tash.
Thank you very much, Val, for your lovely introduction. Good evening, everyone, and thank you for joining us tonight for our July live Q&A, where I will be presenting on the relationship between diabetes and glaucoma. Firstly, I would like to take this opportunity to acknowledge the traditional owners and custodians of our land. Glaucoma Australia respect and honour Aboriginal and Torres Strait Islander elders past, present and future. We acknowledge the stories, traditions and living cultures of Aboriginal and Torres Strait Islander people on this land and commit to building a brighter future together. Apart from having glaucoma, we understand that some of our patients may have other underlying conditions, health conditions. This week is World Diabetes Week, like Val has mentioned previously. So in order to honour this week, we at Glaucoma Australia would like to emphasise the importance of understanding the impact that diabetes has on eye health, especially the relationship between diabetes and glaucoma. During tonight's live Q&A presentation, I will cover the following topics. What is diabetes? Types of diabetes diagnosed within our community. What is diabetic retinopathy? Types of diabetic retinopathy. Neovascular glaucoma. Treatment options, and there will be some time at the end for questions and answers, which I will hopefully be able to provide you. So, what is diabetes? In simple terms, diabetes is a disease that occurs when blood glucose level, or often referred to as blood sugar level, is too high in the body. Glucose is the body's main source of energy. Your body can make glucose, but glucose can also come from the foods that we eat. In order for the glucose to be absorbed by your cells, it requires a hormone called insulin. Insulin is made by the pancreas that helps the glucose to enter your cells and be used by your body as energy. So it's almost like fuel for your body. If you have diabetes, your body doesn't make enough insulin or any insulin at all, or it doesn't use the insulin properly. Glucose then stays in your body and doesn't reach your cells. In a nutshell, diabetes raises the risk of damage to your eyes, your kidneys, your nerves, and the heart. Taking steps to prevent and manage diabetes may lower your risk of developing diabetic-related health problems. Let's now look at the different types of diabetes and their characteristics. In type 1 diabetes, the body makes little to no insulin. The immune system attacks and destroys the cells in the pancreas that makes insulin. Type 1 diabetes is typically diagnosed in kids and young adults who are required to take insulin daily in order to stay alive. In type 2 diabetes, the cells in the body don't tend to use the insulin properly. Your pancreas is making insulin, but not enough to keep your blood sugar level at bay or within the normal range. Type 2 diabetes is the most common type of diabetes in the community. Risk factors such as being overweight or having family history of diabetes play an important factor on whether you will develop diabetes or not. Type 2 diabetes is most commonly diagnosed at a later stage in life, but can also occur in childhood. Adopting a healthier lifestyle, losing weight, and avoiding weight gain can lower the risk of developing type 2 diabetes. Next on our list is gestational diabetes. Gestational diabetes is diagnosed in pregnancy and tends to go away after giving birth. Gestational diabetes is typically a strong indicator that type 2 diabetes may develop later on in life. In pre-diabetes, the blood sugar levels are not high enough for a confirmed diagnosis of diabetes, but are considered to be borderline. In this type of diabetes, your doctor may ask you to adopt a change in your diet or lifestyle, such as starting some form of exercise in order to lower the blood sugar levels. The next type down is monogenic diabetes. This is a rare type of diabetes and is caused by an anomaly in the genetic mutation of a single gene. And lastly, diseases that cause damage to the pancreas, such as cancers, surgery, pancreatitis, which is inflammation of your pancreas, can increase the insulin levels and have a direct impact on glucose absorption and increased blood sugar levels. So what is diabetic retinopathy? Diabetic retinopathy is an eye condition that can cause vision loss and blindness in people who have diabetes. Over time, having too much sugar in the blood affects the blood vessels in the retina. So the retina is basically the yellow surrounding structure inside the eye that is responsible for sending sensitive information to the back of the eye that receives images and sends the images via electrical signals through the optic nerve, which is circled in purple, to the brain. Diabetic retinopathy is the world's leading cause of blindness in the working age population. The risk of diabetic retinopathy increases the longer you have diabetes. Changes in the blood vessels in your retina make it hard for the blood to flow through, leading to blocked blood vessels that leak fluid or bleed. To make up these blood vessels that are quite weak, your retina will make new blood vessels that are even weaker and don't work well. So if you have a look at the diagram on the left-hand side, you can see that that's a healthy eye. The blood vessels appear to be quite unified and normal at the back of the eye. Whereas if you look at the retina on the diagram on the right-hand side, you can see that there are hemorrhages, which are little bleeds in the back of the eye, cotton wool spots, which are lesions that are noted in the back of the eye. There is also macular edema, which is swelling in the most central part of the eye, microaneurysms, which are little bleeds again, and abnormal growth of blood vessels. Now let's take a look at the different types of diabetic retinopathy. There are two types. There is non-proliferative diabetic retinopathy, which can be broken into mild, moderate, and severe, and the more advanced type called proliferative diabetic retinopathy. In non-proliferative diabetic retinopathy, the walls of the blood vessels in the retina weaken. Tiny bulges protrude from the walls of the smaller vessels, sometimes leaking fluid known as the angiogenic factor and blood into the retina. The leaking of the fluid can sometimes occur in the part of the eye that sees color and clarity called the macula. This is referred to as central macular edema or diabetic macular edema. as visible in the middle diagram in the purple circle, and is a common occurrence in people with diabetic retinopathy. CMO or DMO is usually confirmed by your eye doctor with a scan called a macular OCT. Symptoms will include reduced vision as well as distortion of straight lines. The larger retinal vessels can also begin to dilate and become irregular in diameter. As mentioned previously, non-proliferative diabetic retinopathy can be classified further into mild, moderate, and severe form, depending on the changes and signs visible to your eye doctor during your eye examination. The severe type of non-proliferative diabetic retinopathy lies on the cusp of being classified as more advanced type proliferative diabetic retinopathy. So, like I said, in addition to the changes that are occurring in non-proliferative diabetic retinopathy, proliferative diabetic retinopathy is a more advanced stage of the disease where new blood vessels also grow on the surface of the retina. These vessels may break and bleed into the vitreous, which is the clear gel that fills the back of the eye, causing severe vision loss. People who experience a diabetic bleed, or often referred in medical terms as a hemorrhage, can often So these vessels may break and bleed into the vitreous, the clear gel that fills the back of the eye, causing severe vision loss. People who experience a diabetic bleed or hemorrhage, as it's often referred to, inside the eye will notice an increased amount of floaters or black spots, cobwebs, or a curtain in their vision, or may have complete loss of vision as a result. The bleeding can penetrate into the clear jelly, called the vitreous, causing scar tissue that can lead to a retinal detachment. To put it into context, when we cut ourselves, our body creates a scar. Essentially, the same things happen in the back of the eye. The scar tissue created from the bleed that has entered into the jelly, or the vitreous in this case, causes traction, which then pulls away the retina from inside of the eye, causing the retinal detachment and leading to loss of vision. Treatment options for diabetic retinopathy will depend on the stage of diabetic retinopathy and can range from retinal laser, which is pan-retinal photocoagulation, or PRP, to seal off and shrink off the new blood vessels that have formed. Anti-VEGF injections into the eye can also be given to reduce the swelling at the back of the eye and stop the angiogenic factor from causing further harm. Surgical intervention, such as a vitrectomy or removal of the jelly that is often replaced with another substance, or reattachment of the retina, are performed in severe cases. Diabetic retinopathy patients tend to have a higher risk of developing other eye conditions such as cataract and glaucoma. Let's now look at the relationship between diabetes and glaucoma. So the most common diseases for developing neovascular glaucoma, or sometimes referred to as rubeosis, are diabetic retinopathy, which we have just discussed, central retinal vein occlusion, which is essentially a stroke at the back of the eye in one of the major veins, or ocular ischemic syndrome. So basically, not enough blood flow to the eyes due to possible stenosis or a blockage in the carotid artery in the neck. But for the purpose of tonight's presentation, we will only concentrate on why this may happen in diabetic retinopathy. Neovascular glaucoma is a secondary glaucoma where the angle and the iris in the front part of the eye become affected by new blood vessels. Iris is the colored part that surrounds the pupil, and the angle is the space between the iris and the cornea, which is the windscreen of your eye. The new blood vessels are referred to as neovascularization. Neo meaning new, a vascularization meaning blood vessels. Neovascularization occurs as a result of those same fluid or the angiogenic factors that are released and diffused by the weak blood vessels in the back of the eye, which then travel to the front part of the eye, causing neovascularization of the angle or neovascularization of the iris. So if you have a look at the diagram on the right-hand side, you can see that the iris and the angle have lots and lots of new blood vessels forming that should not be there. So the arrows pointing to different blood vessels indicate the blood vessels have formed in the front part of the eye and are causing a lot of problems for this patient. These blood vessels should not be there, and this area should be clear of any blood vessels. So neovascular glaucoma develops as a result of severe diabetic retinopathy and contributes to approximately 4% of all glaucoma cases. Early stages of neovascular glaucoma can include redness, pain, light sensitivity, headaches, and reduced vision. Advanced stages of neovascular glaucoma can cause severe headaches, nausea, vomiting, and complete loss of vision. Your ophthalmologist will examine your eye thoroughly by looking through a microscope where you pop your chin on the chin rest and you push your head against the bar, and he or she will use a special lens to view the back of your eye very thoroughly. He or she will check for signs of this neovascularization in the front part of your eye by performing a gonioscopy. A gonioscopy uses a 3 or 4 mirror lens that rests on the front part of your eye or the windscreen of your eye, which allows your eye doctor to view the structures in more detail and any signs of neovascularization of the iris and the anterior chamber angle. Neovascular glaucoma can be complex to treat, as it needs to be co-managed by a team approach with specialists in both retina and glaucoma. Usually, the pressure inside the eye is reduced with glaucoma drops. And for those who can tolerate the drugs and have no kidney or liver issues, a systemic medication by the name of Diamox is prescribed to lower the eye pressure quickly. Steroids are sometimes prescribed to reduce the inflammation in the eye, and cycloplegics are given when white blood cells or inflammation is present in the anterior chamber or there is evidence of a synechiae. A synechiae is when the iris or the colored part of the eye sticks to the lens and creates further problems. Consideration of laser along with anti-VEGF injections such as Lucentis, Eylea, and Avastin is used to block the angiogenic factors that promote new vessel growth and can sometimes help with regression of that new blood vessels forming. Surgical intervention is indicated when medical therapy is inadequate to control the eye pressure and may include a trabeculectomy, which is a filtration surgery, or a valve implant that will help lower the eye pressure inside the eye. Cyclodiode laser, which attacks the ciliary body that creates the fluid that flows through inside our eye, is performed when there is no vision potential, pressure is still too high, and the pain is not managed. By starting the cyclodiode laser, you are killing off the ciliary body that creates the fluid inside the eye. The last resort is enucleation, where the eye is completely removed and replaced with an artificial eye. Thank you very much for listening to my presentation, and now we can move on to any questions that you may have.
Thank you so much, Tash. That was amazing. And I find it really interesting that you can have pre-diabetes, and I guess that's similar to our suspect glaucoma, that you don't have it, but you still have to be monitored and watched. And I also find it very comforting that if you're having a glaucoma check with the optometrist or the ophthalmologist, there is so much overlap of checking the back of the eye. So you are looking for the glaucoma change, but also diabetic. It's not additional specialized tests you need to have done. So the optom can check that, and when they're checking the front of the eye, etc.
That's right.
That's good. It's
It
great.
really needs to be a thorough check at the back of the eye, including the front part of the eye, so that all aspects are covered.
Yeah, no, that was terrific. Thank you. We have had some questions come through during your presentation. So I'll just start with the first one. How can I tell if diabetes is affecting my eyes? Which is a fantastic question. Thanks, Tash.
That is a fantastic question. So, my answer to that would be: if you have diabetes, your eyes may be affected by it without any symptoms, which is why it's really important to get regular eye checks if you have diabetes by your optometrist or your ophthalmologist. As a result of the various changes in diabetic retinopathy that we have discussed during my presentation, which may occur in your eyes, you may often start with no visual symptoms. As the disease progresses, you will start to experience symptoms that include fluctuating vision. And I used to discuss this with my patients. So fluctuating vision used to happen when the blood sugar levels increase and the vision tends to go blurry. And then as the blood sugar level decreases, the vision clears up. So it's really important that the patients are always observing what their blood sugar levels are doing if their eyes are changing.
Yeah.
Floaters may appear, which are black spots, double vision, and impaired color vision, particularly if there is any swelling or the macula is affected, which is the most central part that actually sees color and clarity.
Yeah, great. Thank you. Thank you. Another terrific question. Can I develop diabetic retinopathy even though my diabetes is always well controlled?
This is a good question too. My short answer to this is yes. Many patients who have had previously been diagnosed with type 1 diabetes and have had it for about 20 years or so can develop diabetic retinopathy, as their blood sugar levels tend to be a bit more variable. Other factors associated with the disease, such as inflammation and direct changes to the blood vessels, are also believed to create retinopathy at the back of the eye. Regular monitoring and control of blood sugar levels is a good indicator if diabetes is controlled or not. These include fasting blood sugar levels, so that means checking your blood sugar level in the morning before you have breakfast and noting it down so that you can provide that information to your doctor or your specialist. And a 3-monthly blood test refers to as the HbA1c by your GP or your endocrinologist. The worst thing for a diabetic is to have very variable blood sugar levels. So, for example, if blood sugar level increases to 20, then reduces down to 5, then the next day increases to 15, and then reduces to 7. The analogy that I could use is like eating so much all the time and then not eating enough the next day. So your stomach tends to become hungry and it starts to feed off the fat from your body. So essentially at the back of the eye, if your blood sugar levels are high, your retina is feeding itself. And so once the blood sugar level decreases quite significantly, it needs to continue feeding itself, but it's feeling very deprived. So what it does, it creates these new blood vessels which are weak, which are leaking, which are not able to be controlled. And these are the blood vessels that actually create a lot of damage at the back of the eye. Okay. So diabetes is, I just wanted to mention that diabetes is a progressive disease like glaucoma, meaning that you cannot stop it, but you can slow its progression. By lowering the eye pressure in your eyes with glaucoma drops, you are slowing the progression of glaucoma. In diabetes, if you have good control of blood sugar levels, you will still slow the progression of the damage, but you will never stop the disease from occurring in your eyes. And you can slow that progression for the rest of your body, causing damage to the rest of your body as well.
Mm-hmm. And I guess that comes down to a similarity with glaucoma: diet, exercise, lifestyle.
That's exactly
it carries over, doesn't it? Another question: if one eye is affected, will the other eye suffer the same fate?
Well, the sign and symptoms of diabetic retinopathy may initially develop in just one eye, for example.
Mm-hmm.
However, in general, both eyes are usually compromised, although not necessarily to the same degree. That is why it is crucial that patients adhere to their regular appointments in order for any changes to be identified by their optometrist or their ophthalmologist.
Mm-hmm. Mm-hmm. Thank you. Now, you mentioned looking at the back of the eye and an OCT scan of the back of the eye, which feeds into this next question. How have the new imaging tests changed the way diabetic retinopathy is studied?
Yeah, so new imaging tests based around optical coherence tomography, or the OCT machine, now provide information, or very valuable information, without any side effects or discomfort to the patient, which is why these techniques are used frequently when you visit your eye specialist. Or your optometrist. Just like glaucoma, where an OCT test is performed to assess any changes of the optic nerve and any thinning of the retinal nerve fiber layer, an OCT in diabetics is performed to observe any changes such as early signs of swelling at the back of the eyes. An OCT can provide valuable information such as effectiveness of treatment received, whether or not swelling has increased or decreased, particularly if they are receiving injections to help reduce the diabetic swelling in that macular area that we were talking about before. Tests like fluorescein angiography, where the dye is injected into the body and photographs are taken before and after the dye travels through the eye, through the blood vessels, are now conducted less frequently and only when they're specifically needed to be done so.
Yeah, thank you. And these imaging tests and machines, they're constantly being refined and
Yes.
using algorithms to identify more and more detail, which is terrific.
Yeah, they're constantly evolving, so it's just amazing of what's to come.
Yes, no, it's terrific. Thank you. I think we might have time for one more question. Can new treatments provide a definitive cure for diabetic retinopathy and diabetic macular edema?
Well, the short answer to this is a big no. Treatments developed in recent years have brought about a considerable improvement in a lifestyle for patients with diabetic retinopathy, because they can decelerate the disease progression and reduce vision loss. Ongoing research provides hope that future treatments will be even more effective. Taking steps to a healthier lifestyle, exercising daily, and eating a well-balanced diet, along with adhering to recommended treatments and having regular eye tests by your optometrist and your ophthalmologists, are all ways in which we can reduce and lower the risk of damage caused to our eyes and our bodies by progressive diseases such as diabetes and glaucoma.
Mm-hmm. Thank you. In the essence of time, they're all the questions we have time for during this presentation, but please, if anyone has any further questions, you can send them to Natasha at glaucoma.org.au, or ring us on our 1800 500 880 number. We have 3 patient educators, Natasha, myself, and Loretto, and we welcome all of your questions. So thank you so much, Tash. That was amazing. And thank you to everyone who joined us this evening. Have a lovely evening.
Thank you very much.
Ta.